Thank you very much indeed for inviting me to do this lecture, and to all of those of you who joined us on today and what can only be described as unusual and difficult times, and I appreciate that you've taken the time and trouble to do that. I chose this because obviously it's uppermost in my mind at the moment, having spent quite a lot of time on the recent version over the last couple of years. And certainly many of you in the audience will be too young to remember how it all started. So back in 2004, 2005, we published the first evidence-based document on Rhinosinusitis. I'd actually done something in 1994, but it hadn't had much of an evidence base at that time. In those days, you just got a group of friends around a table and came up with a good idea. But in 2005, we looked at the evidence, and there was some, but not a lot. In fact, there were only 650 odd references at that time. By 2007, when we revised the document, there were over 1,000 references. And I think one of the main advantages and purposes of EPOS, and it's been, I think, very successful in this, is to really identify the gaps in our knowledge, which are numerous, but then to try and stimulate and initiate research to fill those gaps. And I think in that respect, it has been successful. And so you then see a third iteration in 2012. Now, you may say, well, why did we bother to wait until now, 8 years, in order to launch this document? And it's a good question. Doing these consensus things is not an easy process. So we wanted to make sure it was worthwhile doing it. And we knew that there was a whole raft of the biologics and other treatments coming along, and we wanted to include those in the next publication. There have also been a lot of changes in our concepts of the pathophysiology of rhinosinusitis and its treatment. And so that really was why we waited until last year to start this process. Now, I could stop here and just say, go onto the Rhinology Journal website, download the document, which you can for free, and there you are, Bob's your uncle. And if that is a bridge too far, because there are 465 pages of the full document, then there is an executive summary actually that was published in Rhinology recently. That's a useful condensation of the document. I would say that it doesn't have that much on surgery in it, which is perhaps a reflection of the sort of level of quality evidence, but nonetheless, if you're interested, there's a lot in the new document. Now, this is not the work of one or two women, this is the work of many people. And we put together a steering group of 47 internationals of experts and stakeholders from a very wide range of disciplines, not just clinical rhinology, but lots of other areas. And we included for the first time pharmacists, nurses, and above all, we had quite a big input from patients. And I think that's really critical these days in producing documents like this. And having completed it, we then sent it out to another 104 experts all over the world. So in total, the document, which we call European, but is actually, as you can see, a pretty international effort, has input from over 69 countries in every continent except Antarctica. So what's new? Well, obviously, it's a massive update on all that's gone before. We looked carefully at classification, at definitions, and we also tried to come up with some preferred terminology for future publications. We looked at pathophysiology. We were particularly interested in the issue of control versus cure, and the pediatric section, which I'm not really going to have a lot of time to talk about today, but that has been completely rewritten and considerably expanded. We've also altered our concepts for surgery, and as the ever popular algorithms have now morphed into integrated care pathways, there's plenty of those, as well as a very long list of research needs. Now, as I say, doing a consensus document in the past used to be a very straightforward thing, but now it's become very, very complicated. Somerset Maugham said it's easier for 3 people to produce a baby than for the 3 people to produce a book. Of course, that was in the days before IVF, but it's a well-taken phrase. It is quite difficult sometimes to get people to agree. I think there's a study to be had in actually producing consensus documents. But we did use some well-formulated methodology. We used the Agree-2 framework to look for consistency and clarity and transparency. mixed methodologies. Now, the real crux of this, there was enough literature for most things to just look at the evidence base, systematic reviews and meta-analyses. And that meant that quite a lot of what you might think were quite good studies actually were left out. Of course, there's lots of areas where we don't have an answer or literature to answer it. And in those, we try to do Delphis, again, another minefield for anybody who's had anything to do with them. But we did use Delphi for a number of questions. So Vitska and I started off with the help of a medical information expert, or a librarian to you and me, who managed to find 30,000 references on rhinosinusitis, just RCTs and systematic reviews pretty much. I mean, really, I was amazed. And then we had to go through them all on Rayan and Mendeley, and we got it down to just over 3,500, and that was quite a task over last Christmas, New Year, I can tell you. Only published literature was accepted, so there are quite a few studies in the offing at the moment from some of the companies which was not included because they have not been accepted at the point we went to press. And then, of course, most of it was done online, but we had a few face-to-face meetings coincident with some other international meetings that were happening. Now, why bother? I mean, obviously, I'm going to concentrate today on chronic rhinosinusitis. The document looks at acute as well. It looks at adult and children. But if we just look at adults with chronic rhinosinusitis, the Galen study, which we did a few years back, shows it's a very common problem. There are differences between countries, obviously. About 11% of the populations thought to suffer from chronic rhinosinusitis. And of those, and I'm going to use the term chronic rhinosinusitis for nasal polyps at the moment, but we'll talk about that in a second. About 2% could be said to have eosinophilic dominated disease. It's a very expensive condition. We know from studies done in the US and in Europe, about $2,500 or euros a year are spent on patients. So it's likely to be about £2,000 in the UK, although those studies have not really been done in any great detail. Of course, there are differences. In the USA, the average cost for an operation for CRS is $11,000, whereas in India, it's only 1,100. But we do know that healthcare spending has been significantly greater in CRS than in other chronic diseases. And that, you know, has an important impact economically. And of course, we're not just talking about direct costs, we're talking about indirect costs, which in the case of rhinosinusitis account for 40% of the total. It's a very costly condition, not just because people miss time off work, which they do, but because many people go to work with the condition and don't work to their full capacity. So again, in the States, the estimated cost of indirect cost of CRS is another $20 billion. It's a huge amount of money. We also know that it's not just a burden financially, it's a burden on quality of life and your ability to function, as evidenced by the presentism. And in these early studies done by Ralph Metzen and colleagues, it was shown to be have a greater impact on quality of life than conditions like angina, insulin-dependent diabetes, chronic obstructive airway disease. So, you know, this is still a very important disease. And if we look on a SNOT-22, the average sort of control score, normal population is just over 9, whereas patients with CRS are scoring 42. And interestingly, those with what we might call a Th1 dominated disease scoring slightly higher. Now, when we talk about CRS, I mean, obviously we're talking about a very heterogeneous condition. We know that there's a huge number of overlapping etiologies, predisposing factors, comorbidity, systemic disease, etc., which will impact on this condition. And that's putting aside things like alcohol and smoking. And we also know that there is an important relationship. We like to think of the respiratory tract as being a single organ. And therefore, you know, we have to take on board that interaction. And it's something we've always embraced in EPOS, not just because it makes sense and it's pathologically true, but because a lot of what we do and a lot of what we use to treat actually comes from the lower respiratory tract. The concepts of phenotyping and endotyping came from asthma and other respiratory conditions. And indeed, many of the medications that I'm going to talk about started off as treatments for asthma. So it's a very important interrelationship. Now, when we talk about categorization of CRS, obviously the words phenotyping and endotyping pop up all the time now. And back in the day, you know, it was a very simple thing. You had inflammation, and some of those patients had nasal polyps and some of them didn't. And it was a very sort of binary thing. And of course, the literature reflects that. And that's why we can't completely get away from using the terminology CRS with and without nasal polyps. But we also recognize now that it's not just two phenotypes, it's many different phenotypes, as this slide from Vitska shows us. I mean, we could try and talk about it as a spectrum rather than as being something specific either with or without. And people have tried to do this using perhaps eosinophilia as the marker, looking at the difference between T2 and T1 dominated disease. But we know that even that is not that simple, because when we look at the Galen study where we did a cluster analysis, even in patients where you think, oh, it's pretty straightforward, these patients have got polyps, the Th2 disease, they've got lots of IL-5, even in that group, we see a very wide range of different endotypes. And all that I have said is applying really to patients in the West, where we're talking about an eosinophil dominated disease. But we all now know that there are certain parts of the world, particularly in the Far East, where that eosinophilia was not and has not been as marked. And there are many studies now showing that. But what's even more intriguing is that with the passage of time, particularly in some very nice longitudinal studies from Japan, we see that there is a move towards a more eosinophilic disease. I like to call it, I haven't been sued so far, but I like to call it the McDonald's effect. We don't really know why this is happening, but clearly there is something happening that is influencing this pathology to change in this way. Now, we could spend the entire 45 minutes talking about the etiology and pathogenesis of CRS. This is a slide actually from Rob Kern, which we've used in the document. And I think that what it does really is kind of exemplify the multitude of known and unknown factors which come from our host or from the environment, which come together to constitute the different endotypes. And we know that when we look at what happens across mucosal barriers, if the barrier is breached, then there is an intrinsic response, cellular terms, in cytokine terms, which you can broadly divide up into T1, viral response, T2, parasite response, and T3, which is sort of bacterial and fungi. And what the body does is to try and eliminate those features and restore the barrier. But in CRS, that doesn't happen. And you see this either with these responses, T1, T2, T3, or a combination of them. And in the case of a T2 response, it's going to be driven by cytokines such as IL-4, IL-5, IL-13, and also activation of things like eosinophils and mast cells. And it will result, to a greater or lesser extent, in degrees of remodeling. And one of the reasons that things have sort of changed, I wouldn't say quickly, but have sort of moved along quite a bit in the last few years, is that the drug companies essentially are trying to target this point to try and prevent that remodeling and also to respond in particular to the type 2 response, which you see in asthma, but which we can see also in CRS. And that's made a big difference. Now, I said we didn't want to use the term with and without nasal polyps. And so what we've gone for is a classification which Richard Harvey and his colleagues sort of came up with originally and modified it so that we've got basically primary and secondary CRS, and then we've divided it by anatomic distribution. So it's either localized or diffuse, and then we can try and add an endotype approach to that, looking at in the primary case, whether it's type 2 or not type 2. And then we have on the further side examples of the phenotype. And I just draw your attention to the box here, where we've got obviously patients with polyps, but it also recognizes that there are a group of patients who have eosinophilic responses in their rhinosinusitis, but they don't have polyps. And this might be quite important in the future for treatment. We look at the secondary CRS, again, localized and diffuse. Here we've got sort of more of a pathological approach to it. And then we've got examples of what you might call specific pathologies and systemic diseases rather, which can manifest themselves in CRS or affect the way it behaves. And there you see primary ciliary dyskinesia, the vasculitis, and immunodeficiencies, etc. Now, when we come to the definition in adults, it hasn't really changed. I mean, itis is inflammation. We can't argue with that. It applies to both acute and chronic. And there are some predominant symptoms. There's a limited way in which the nose can manifest inflammation symptomatically, blockage and discharge. In the case of adults, there's more often effect on the sense of smell. And perhaps in children, cough is thought to predominate, although it may simply be the fact that children, it's not so easy to test smell and they don't complain of it so much. In addition to the symptoms, we're still going to use some clinical findings such as endoscopic appearances and imaging to corroborate our clinical findings. And in terms of severity and duration, we've still used the same classification. We know that the visual analog score and indeed the SNOT-22 correlate quite well with the stratification into mild, moderate and severe. And we're pretty much stuck with the duration because the regulatory authorities are still using greater than 12 weeks for CRS and other chronic conditions. And obviously acute is less than 12 weeks, but we know that more often that's a much shorter condition and has complete resolution of symptoms. There are other conditions as well that we have to define when we're looking at this area. Obviously, patients may have acute exacerbations, worsening of symptoms, but returning to a baseline of CRS symptoms in between, and also recurrent acute rhinosinusitis. There's a whole section on that in the document, which we've defined as 4 or greater than 4 episodes a year with symptom-free intervals. Not that common, but there is a body of literature that specifically looks at that condition. If we look at the prevalence of the cardinal symptoms of CRS, it's quite interesting. There is some difference in the different settings. We've got patients in the general population and compare them with an outpatient clinic or those undergoing surgery. Nasal obstruction remains the sort of commonest complaint, but certainly with things like sense of smell and facial pain, there are some fluctuations and differences between these different settings. And if we look at the severity of the symptoms, again, nasal obstruction scores pretty highly in most situations, but the other symptoms are not too far behind. And there's less, I think, wiggle room there between the different settings. Now, obviously, a lot of our patients get better, but not all of them get better. We coined this phrase in 2012, difficult to treat rhinosinusitis. It reminds me of Ian Mackay to say, what have you got? You've got difficult to treat rhinosinusitis. Not much comfort for the patient. But what we're basically saying here is that you've got persistent symptoms despite appropriate treatment. That was something that we had a lot of discussion about, the terminology. Was it maximal, appropriate, adequate, et cetera, et cetera. Anyway, the term now at the moment, this week, is appropriate treatment. So patients have not achieved an acceptable level of control. Now, this idea of control, I think, is a really important one. We espoused it first in 2012. It comes from asthma. And it's a really important thing, I think, in how we approach CRS, because we're not talking about curing it. And I think this is something that everybody has to understand, us, the patients, the payees, the payers, etc. And you can categorize it, and we've done this in a table where we've divided it up into controlled, partially controlled, or uncontrolled. And the way in which that is determined is looking at the symptom profile, a quality of life marker, in this case sleep disturbance or fatigue, endoscopic appearances, if that's undertaken, and the use of rescue medication. And it can be a very simple sort of aid memoir in the clinic, if you like, or if you want to use it for research, you can apply a visual analog score. And I do think it's a very useful concept when looking at how patients respond to treatment. Now, there are a whole raft of reasons for lack of control. And this diagram comes from Peter Helling's article. Essentially, he's divided it up into diagnosis-related things, disease-related, additional conditions, comorbidities, etc., patient-related factors, and indeed treatment-related predictors. And we have to, recognize that there are a number of diagnostic issues. We may have a differential and get problems because we mistake CRS for allergic or non-allergic rhinitis. We're all too aware at the moment of other causes of olfactory loss with COVID. And of course, facial pain is a whole other can of worms when it comes to CRS. And then of course, there's a whole raft of concomitant diseases, and these all have their separate chapters in EPOS. I don't have time to go into them in detail, but we have to bear these in mind when we see our patients with these conditions. And so the first of the algorithms, or they've now, as I say, integrated care pathways. So what we've got here is a stratification of the patient in sort of self-care, over-the-counter treatment, primary care, and secondary and tertiary care. Kicking off with our symptoms, longer than 12 weeks, whatever's available, doesn't work, goes to the GP. Here we have some basic treatments, and if that works, that's fine. If it doesn't work, then the patient may be referred into secondary and or tertiary care. And then we can apply our classification, and here we have the diffuse localized classification, and that in turn leads us on into our management schemes. But obviously bearing in mind that if there is any doubt, we don't think it's CRS, or any of these, what used to be called red flags, but in this case in the purple box, alarm symptoms are ringing, then clearly we're going to go for other imaging and other investigations to try and sort this out. Of course, there is a whole raft of diagnostic assessments and tests that we can do. And again, I've sort of stratified it according to sort of primary, secondary and tertiary care. These things are not going to be done on every patient, and it will very much depend on what's available. But we start off clearly with history and examination, and then move on through these things. I made this little sort of timeline for myself a while back when I was giving a lecture, looking at sort of the history of CRS treatment. I think it was quite entertaining, really, because we've got all the operations that were sort of developed in the distant past. Then we had our sort of big breakthrough with endoscopic surgery in the 1980s. And I've left it blank after that, although you may feel that's a bit harsh because things have altered. They've been nuancing, I would say. And then, of course, sorry, we've got all these other medications, starting off with douching in the midst of time, again, right the way up to the present time. So basically, that leaves us with a pretty long list of possible medical treatments in CRS. And here you can see, I couldn't possibly go through all of these in detail. I'm going to try and talk a little bit about each of these approaches. There are a lot of other things that can be used, obviously, for which there is positive evidence. And then there are a list of other medications that have been tried, have been subject to randomized controlled trials, but have not so far shown to be better than placebo. That can change in the future, but that was the present state of play when we wrote the EPOS. So what about steroids then? Well, we've had them for a long time. They're safe, they're effective. There's lots of RCTs showing that they work on symptoms, quality of life, and improving appearance of nasal polyps. There's not much to choose between the different steroids, to be honest, and the side effects are frankly pretty negligible. And as before, we've shown that they work best when there's a cavity. The document, the EPOS document, is full of forest plots, blobograms, I call them. You can see here, for what it's worth, that the little box down here is on the correct side of the line. We'll come back to that in a minute. Now, one thing we looked at in quite a bit of detail was this business of intranasal corticosteroid irrigation, which is all the rage now, particularly in the States. I sort of feel it may have come in partly because they don't have Flixonase nasules there, and so they started using the Pulmicort respules, but didn't feel quite comfortable just putting those straight in the nose and added them to the irrigation. And it has become extremely popular. And I reviewed all the literature a couple of years back for the American consensus document. But the reality is that there are precious few true randomized controlled trials. I mean, I appreciate it's difficult to have a randomized placebo-controlled trial, but you can do it. Saline versus budesonide. There's 3 of them in the literature. And then more recently, there is one using the metazone. Variable dosage, variable duration, lots of different outcomes. None of the RCTs in budesonide showed a significant difference in favour of the addition of the steroid. It hasn't stopped it being used, but there isn't the evidence to support it. For the mometasone, however, there was a significant improvement in the visual analog score, SNOT, and in the CT Lund-Mackay score. So at the moment, I think there is a little question mark about it. I dare say there will be more randomised controlled trials done to try and prove the point, but at the moment, it's a little bit flaky. Niels Mergind, who none of you will remember, but was a great rhinologist back in the 70s and 80s, said, why treat 70 kilograms when you can treat 2 grams? And he was referring to intranasal corticosteroids, which he was instrumental in introducing. And so now we've sort of turned the wheel back, and here we are with eluting stents and different delivery devices. And indeed, this may be a very useful way forward. There's quite a lot of interest in these. Most of these studies they all come from the States, in fact. And looking at the use of eluting stents in the office, these are patients who have not had previous surgery necessarily, and looking at whether or not the stent can reduce the need for surgery, reduce the size of polyps and symptoms. And indeed, in these 3 studies, which did have all the same dosage over a 90-day period, there was evidence on our globogram for the corticosteroid. So these sort of approaches may have value in the future, although of course they don't come cheap. What about short courses of systemic corticosteroids? We all know that oral corticosteroids work in nasal polyps, but it took a long time to get some proper randomized controlled trials. There are 7 in the literature, 409 patients, mainly using oral prednisolone, but as you can see, they're not drug sponsored. So variable dosage, variable duration, variable follow-up, quite a few different outcomes, and all of them generally showing improvement in the outcomes at 2 to 3 weeks. The problem is that if you carry on looking at the patients, time, those improvements start to dwindle. And what's interesting is they dwindle despite the fact that the nasal polyp score is often still reduced. So if we look at the little forest plot here, I've compared here the difference between the total symptom score for systemic steroid and placebo at 2 to 3 weeks and 10 to 12 weeks, and you can see the deterioration. For the actual polyp size, there is a deterioration, but it's still significantly better at 10 to 12 weeks than it was with placebo or before they started. So I think there is a role, but of course we have to consider side effects and the fact that patients become resistant with time, etc., etc. So it's not a perfect solution. Nasal rinsing or irrigation. We always used to call it douching, but the approved term now is irrigation and rinsing. Apparently the French objected to douching because it had some unpleasant gynecological references. So here we are, rinsing, and we have lots of different types of solutions and methodology. There's no real placebo arm, is there? I mean, you've got to have something to put in the nose. So the comparisons are various, but at the end of the day, out of this of RCTs, we've got 20 showing improvement in the objective outcomes. Isotonic saline or ringers being better than hypertonic, but there's still a big question mark. You know, what's the best method? Concentration, volume, pressure, frequency, temperature, head position? We don't know. Nonetheless, we can recommend it. It does work, but we can't recommend one method over the other. Can we add anything to it? Yes, we can. There's quite good evidence for adding xylitol, sodium hyaluronate, and xyloglucone, if you can find it. Not such good evidence for some of these other things, although there are studies in the literature looking at them. On to antibiotics then. Well, here we've got to make a distinction between short and long-term antibiotics. Quite a range in the literature, but we agreed that it had to be 4 weeks or less for short-term and greater than 4 weeks for long-term. And of course, they're being given for different reasons. The short-term generally is being given for an acute bacterial infection, whereas with the longer term, we're looking more towards the immunomodulatory properties. Now, by and large, the short courses in chronic rhinosinusitis are not particularly effective. There's very little evidence. Side effects, particularly gastrointestinal, are relatively common. It's not recommended. This study, which is quite interesting from our colleagues in Ghent, looked at doxycycline as a treatment in patients with polyps. They chose a 3-week regime, and so it really doesn't fulfill the criteria of a long-term course. And it was an interesting study because it was compared with prednisolone and a placebo. And you can see here that the methylprednisolone did rather well, but then, as we've just seen, it tailed off. And at the end of the follow-up period, the doxycycline, which had started slowly and it improved, sort of carried on. It's a bit like the hair of the tortoise. And at the end of the follow-up period, it was significantly better, but I think we can honestly agree that it was only just significantly better. So there's a little bit of a question mark hanging over that. Then, of course, we move on to the macrolides, something close to my heart, something that's been around for a long time, used in Japan for non-eosinophilic panbronchiolitis, very unpleasant disease that killed patients. And someone hit on the idea of giving erythromycin in a low dose for periods of up to a year or more, and showed that these patients were surviving. Survival went up from 12 to 90% with overall improvement. But the levels in the blood and the sputum were very low. It wasn't acting as an antibiotic as such. And some of these patients also had sinus problems, and that seemed to improve as well. So this type of treatment has been used a lot in the lower respiratory tract. And then in the early 1990s, there were publications appearing saying it could be of use in chronic rhinosinusitis. Now, we don't have time to go through all of this, but we know that the macrolides have quite interesting immunomodulatory properties, some of which I've listed here. And we can say that, these are often important features that we see in the pathophysiology of CRS. So we've got a whole raft of open studies. Well, they just go in the bin because they're not randomized controlled trials. But we do have 2 studies which are quite interesting. One done by Australian colleagues using roxithromycin, and us with our azithromycin study, both 12 weeks long, both looking at patients with CRS, but in our study also patients with and without nasal polyps. I really do not know to this day why we chose the regime we did. It was 500 milligrams of azithromycin a week, not a day, a week. And in the roxithromycin study, they showed that there was improvement, and furthermore, if the patients had normal or low IgE, they did much better with the macrolide. We didn't even bother to measure the IgE. Whole thing was a bit of a fiasco. The problem is, you see, now we've got the 2 together in a blobbergram. So we've got one pretty dire study, I admit it, and this other study, quite a good study, and of course they sort of kind of cancel each other out. And so that means that giving a recommendation to use macrolides based on this is quite tricky, and therein sometimes lies the rub when you strictly apply criteria. Now, there are some randomized controlled trials. Obviously, we compared erythromycin to surgery or the antibiotic, but there was not a placebo arm, so that goes out. These 2 did look at clarithromycin with a placebo arm and did show some improvement. And it has to be said that not all macrolides are equal. This is quite an old study now, but it did show that clarithromycin actually worked rather better than erythromycin in the treatment of CRS. Now, there are lots of studies in the literature, 17 in this meta-analysis, supposedly meta-analysis that was published in last year. But I have to tell you that the group who were looking at all the medication binned most of these on grounds of methodology. So, interesting. We might ask the question, why are we bothering to give this stuff for as long as we do? Well, it's because of the time it takes to get the maximum immunomodulation. If you look at 2 weeks, very few patients are improved with a low dose. Wait till 12 weeks, and quite a lot, if they're going to, will show improvement. Of course, all of these things have side effects, and we have to be aware of that. Resistance is potentially a big issue if we're going to use long-term low-dose antibiotics. Japanese say they haven't come across it. They've been using it for years for this lower respiratory tract problem, something we have to be aware of. Drug interactions, very important to take careful histories to avoid any toxicity. And of course, this issue about QT prolongation and arrhythmias. Now, nobody quite knows why this can happen. with macrolides, and whether it's a class effect or it's specific to clarithromycin. There have been a lot of studies now, big epidemiological studies, showing that there is a small short-term increase in cardiac events, an estimated 1.79 excess in this latest meta-analysis done by Wong and colleagues. That does not continue after the antibiotic finishes, and they weren't able to show a long-term risk, but of course they weren't looking at our long-term antibiotic studies. There was a lot of work done as part of the macro trial, and one of those studies looked at the use of macrolides versus penicillin in the general practice setting for patients with CRS. And here you see that they're pretty comparable, though, to be honest, there was a non-significant trend regarding myocardial infarct within the first 30 days that applied to any macrolide. So that was published last year, and it's something we need to be aware of. I mean, are macrolides safe to use? Yes, I think they are. We certainly still use them, but you do need to take a full drug and cardiac history, and if you're concerned, I think you genuinely should think about doing an ECG. At least you can say the patient didn't have any QT prolongation. So the patients that are going to benefit from the macrolides, if at all, are those who have a T1 non-eosinophilic dominated disease. What do we say in EPOS? Well, there's a lot of argument went on, you could imagine, but we were uncertain. I think we can agree on that. And at the end, it said there is a need for the larger high-quality trials that are presently being undertaken in Europe. Correct. And here it is. So many of you will be involved with this or aware of it, something that Claire and Carl set up. £2.2 million from our National Institute for Health Research, and a fantastic trial which includes a placebo arm, but of course, unfortunately, on hold at the moment since COVID. So about 160 patients have been recruited. We will have the answer, but not just yet. Topical antibiotics, what about those? Well, there have been studies in the literature where they have been added to other solutions. So far, no benefit from adding the topical antibiotic to whatever was the solution used. So back to the algorithms. This is one step on from the last one I showed you. Here we've got patients diffuse or bilateral chronic rhinosinusitis. They've failed their primary care, they've ended up in ENT, and now we have the opportunity to start to divide them up. Have they got a disease which is dominated by the eosinophils or not? And that can be relatively easily sorted out by doing a simple blood test. Then what? Well, then we've got a choice. We do have the option of using a long-term antibiotic. We do have the option of using an oral corticosteroid, and we have the option of surgery. Now, this is a huge section in EPOS, and I can't possibly do it all justice. But let's just say that when to operate, well, after appropriate medical treatment, whatever that might be, there's a huge variation in rates of surgery if you look around the world. And there are studies which suggest that actually making patients wait a long time for surgery are not such a good idea. This is from Tim Smith. He's done a lot of studies looking at these sort of issues. Obviously, they're American, but even so, I think we can say that there's quite good evidence that patients who undergo surgery do often get a significant benefit. Here they are in this line here, which is better than some of the patients who are in the medical cohort. And they often will cross over, as they did in this particular study. It's also relatively cheaper to offer the surgery rather than keeping patients on long-term medication coming back time and time again. And in this study by Rudnick and colleagues, there was a 74% certainty that endoscopic surgery is more cost-effective and becomes so by the third post-operative year. So these are sort of quite interesting indicators. Now, obviously, we can all agree that you have to have a CT scan done before you have endoscopic surgery. We had to do a Delphi to actually prove that. But then I asked the question, it's a minefield doing Delphis, how you phrase the question. But it's interesting because the steering group was made up of a very wide range of experts in ENT. What if the patient came with a scan that was done 6 to 12 months ago? Was it okay to use that? Not sure. What if it was 3 years old? Well, then that wasn't a good idea. So there are all these sort of nuances for which there isn't a lot in the literature, but which, you know, need to be sorted out. We know from the literature that you need intranasal corticosteroids optimally before the surgery. It will reduce blood loss, improve the field and the operation time. And we know that, okay, there aren't any placebo-controlled studies, but there are lots and lots of case series, cohorts, many of them prospective now, which show that surgery does work. And if you take this sort of baseline 89% success rate, which is often quoted, that is actually comparing rather well with some of our medical treatments. You're all familiar with the sinonasal audit. There are quite a few other prospective studies now in the literature, but this still remains one of the largest and longest. Patients do well. They are often well for 5 years. There is a significant improvement in their snot, which is much greater than the minimal clinically important difference. But we also need to bear in mind when we're recruiting patients that, you know, there is a base level at which patients who have low scores probably won't do well from their treatment. This little graph just shows that that improvement is maintained throughout the period. The patients who had polyps in this particular study did better than those without. It seems intuitively correct, doesn't it, that if we do a smaller operation, then the patients will do less well. But it took 5 years to actually demonstrate that. Now, there are lots of reasons. We can talk about it, but we don't have time. It's important to think that there are obviously differences, and we have to consider surgical extent, as we will in a minute. There are different ways of optimizing surgical field. We looked at all the literature on position patient. Reverse Trendelenburg is supported by the literature. Local anesthesia, invasive constrictors, definitely lots of evidence there. TIVA as an anesthetic approach definitely seems to be beneficial in endoscopic surgery, and as is the use of tranexamic acid. Does it matter how long you wait for your surgery? The longer you wait from the longer duration of symptoms, does that give you a better or worse result? Well, the evidence seems to suggest that you need to have your surgery earlier rather than later, by which I don't mean within a couple of weeks, but, you know, within a year, perhaps, of the onset of your symptoms. Mike Beddinger showed in this particular study that patients who had waited for less than a year had much fewer in the way of visits and prescriptions as compared to patients who had to wait for a much longer period. And many of you will be familiar with this paper that we did based on the sinonasal audit, showing that if you were in the early cohort, patients with symptoms who had their surgery with symptoms for less than 12 months, they did better every time point in terms of their outcome as compared to those who waited for longer than 5 years. Now, again, we don't know why that is. I mean, there are lots of possible reasons, and some of them are listed here. It could simply be, we've seen that if you've had surgery, you get a better effect from the saline and the intranasal corticosteroids. So maybe that is the reason, but there are other possibilities. How much are you going to do? Surgeons endlessly argue about this, don't they, at meetings? I mean, it's very difficult to get to the bottom of it, frankly. What's the definition of functional surgery? Well, we got everybody to agree that it involved creating a sinus cavity that incorporated the natural ostium, allowed ventilation, and facilitated mucociliary clearance and installation of topical therapies. But that instantly takes us on to other terminology. What's a full FES? Well, here's the definition here. Everybody agreed on this. But what's the difference between a full FES and an extended S? Well, here you see this takes us beyond the sinuses. And then you have terms like radical, complete, and other terms such as rebooting and nasalization. So it is a bit of a minefield out there. We've tried to add in definitions to make it easier to compare the literature. And then there are all the arguments and debates about all these little nuances which worry us a great deal, but whether they make a big difference or not, you'll have to look in the book. Post-operative intervention, whole big subject all of its own. Debridement, well, we're all wedded to taking the crust out at some point. The evidence is actually not that great. Saline irrigations certainly seem to help. Antibiotics don't seem to make any difference. And corticosteroids, oral and topical, certainly help post-operatively. And so back we go to our care pathway. Doesn't always work, does it? Long-term antibiotics, endoscopic surgery, what are you going to do? Well, here's our additional therapies box at the bottom here. And we have revision surgery and some of the newer treatments. Now, this is where it gets interesting in a way, because now we have to think about potential targets for the newer treatments. And there's a whole list of things that we might use, particularly in the eosinophilia dominated disease. And this diagram, which Harsha Kariwasam lent me, exemplifies where these points, the targets are. And there are quite a few of them, and they have been looked at and are being looked at by the pharmaceutical industry in great detail. Omalizumab's been around for a long time. It was used originally for seasonal allergic rhinitis. It has now been used in chronic rhinosinusitis with nasal polyps. Only 2 trials in the literature at the moment, but there's a whole pile of them coming along. They showed improvement. There are the potential for side effects, but actually there's a long history of using it in allergy and asthma without very much in the way of problems. This is one of the early studies. We know that a lot of these have come from Klaus Backert and Philippe Javert in Ghent in Belgium. A small study, quite a while back now, but showing significant improvement in the patients with and without the drug. We did a little study, Harsha and Simon and colleagues, looking at patients who had severe asthma, who were able to get their omalizumab that way, and we were able to compare them with endoscopic surgery. They both showed improvement, surgery and omalizumab, to the same extent. It's a very short study, it isn't placebo-controlled, etc. But at the moment, unfortunately, there are insufficient studies to recommend omalizumab. I guarantee by the end of the year that will change. Anti-IL-5, obviously very interesting. It's licensed for severe asthma in Europe and the States. There are other anti-IL-5 drugs. Mepolizumab is the one that's had the most attention, and indeed there are 2 randomized controlled trials. This again, an early one from Philippe Javert. But what's interesting about this is that in the follow-up, eventually the patients go back to baseline. And I think this is one of the conundrums that we have with these drugs. Are they going to need to be given regularly, long-term, with top-up, etc.? In the study that I was involved with, we looked at patients with 750 milligrams given intravenously every month for 6 months against placebo. It did well. It helped reduce the need for surgical intervention, and it produced an improvement in olfaction. However, there's been a recent study which is just completed, which I know many colleagues have been involved with around the country, and this hasn't been published yet. It uses subcutaneous and a much lower dose of the drug, and that indeed has also showed significant improvement in the endpoints. But the problem with MePO is that there may be a problem with a sort of residual population of resistant eosinophils. So nobody's quite sure if it will carry on working indefinitely. The one that's had a lot of attention, of course, is dupilumab. It's the only one that's been approved so far for CRS with polyps. It's been used in atopic dermatitis and asthma. And here in the forest plot, you can see that it gives very significant effect in these 2 studies, both from Klaus Backert's group, and this is a little bit more detailed appearance of that study. So we can see that here we have a raft of drugs coming along. There are many other potential agents. We've talked about them in the document. They haven't yet come onto the market. There are lots of studies being done, and as they come available, we will update EPOS accordingly. But it's not cheap. It's an enormously expensive treatment. These figures do change after negotiations between the companies and the health authorities, but it's a serious commitment financially. And at the moment, I think if you've got somebody who's got severe uncontrolled asthma, then it's worth considering it for a patient with very severe polyps. But what we really need to show is that these treatments avoid other treatments. They avoid surgery. They don't just delay them. Now, because of this, we've had to offer some indications for treatment. There are little sort of forms that you have to sort of complete really to decide whether or not to start these things. Patients with polyps, both sides, who previously had surgery and who tick off at least 3 of these criteria. And having started the drug, a bit like getting out of lockdown, you've got to have a get out strategy. And here again, we've got criteria have to be completed at 16 weeks and at a year to see if the treatment should continue. Because if it doesn't work, then it needs to be stopped and the money saved. And finally, when we're talking about sort of directed treatment, let's not forget that aspirin desensitization is still something which may be of value. There's good evidence for oral desensitization. Colleagues in the UK are using lysine. The evidence for that is not so good at the moment, but it's likely to change. Oral aspirin can be used and as a desensitization and then maintained. And indeed, there is quite a lot of evidence for it. You've just got to watch out about GI tract problems. So at the moment, the holy grail really is looking for the ideal biomarker. And there's lots of possibilities. If we look at the drugs, the sort of immune parameters that could be measured, there are lots of different options. And we need to choose something which is going to be easy and cheap to do. And at the moment, the sort of obvious one is the eosinophil. It's quite a good surrogate for Th2 disease. It's cheap and easy to do. And you can look at it in the blood or indeed in the tissue on histology. So what can we do with these patients? We've got biologics and we've got revision surgery. We know that quite a few patients will end up needing revision surgery, particularly if we follow them up long enough. There are certain things that will predict success for our patients. Consistently, a higher pre-op visual amex score on SNOT-22 is the patient who will get the greatest benefit from the surgery. But we also know that there are lots of predictors of poor outcomeness, which I've listed here and which you're all familiar with. There are technical problems. Perhaps we make more of these than we might, but they're certainly there in some of the patients we see who've had previous surgery and yet they haven't had perhaps what we would regard as adequate complete surgery. And we know that once these irreversible pathologies have established themselves, particularly new bone formation and significant remodeling, it's very difficult to reverse those patients. So finally, I just want to say a couple of words about precision medicine. We started off, when I started, opinion-based medicine. What your professor said was what happened and what was correct. Then we've moved on to guidelines, which were eventually supported by evidence. And now we see precision medicine. It's just another way of intelligently applying evidence-based medicine. And we can look at that in the various situations of primary, secondary, and tertiary care. We need to look at prediction of success so we can inform our patients. We need to engage with them. It's got to be patient-centered and with them involved. It'd be nice if we could try and prevent some of these things happening, but ultimately what we're trying to do is sort of go for a personalized care, which will ultimately save money. I'm actively involved with Euphoria. It's an independent organization that works in collaboration with ERS and IACI, etc. It's for research and education in allergy and airway diseases. And they have spent a lot of time trying to look at ways of engaging with patients. And they've done this through various apps. Have one for allergy. This is the one for Rhinosinusitis. It allows a more sort of integrated approach to how patients are responding to their treatment. You may regard that with fear and worry, or you may regard it as a wonderful thing and embrace it. But this is obviously the future. This is how things will likely be managed. If you want to boil it all down and say, well, what are we going to do? Then I would say that this little scheme, which Klaus Backer put together and which I modified slightly, is a good place to start. We've got a patient who's got non-eosinophil dominated disease. They get to the point where they need something doing. Think of macrolides, think of what we might call a mucosa sparing procedure. If they've got eosinophilic disease, you can stratify it by how severe it is, and you can look corticosteroids and perhaps a somewhat more complete procedure. And if they're in the really worst category, then they may be a candidate for either oral corticosteroids, biologics ultimately, or one of the more complete rebooting nasalization or radical procedures. So the message then is not cure, but control. I think it's important that we get that across, and it's an ongoing problem that's going to be lifelong. It's very difficult to really get patients back to perfection. And the EPOS, I hope, has helped to put that message across. Obviously, we were going to launch it in Thessaloniki. That's been deferred till May. We do have quite an active program with this version of the document to get it out there through social media, patient organizations, articles in ENT News. It'll be translated into a number of languages, Chinese, Spanish, Portuguese, etc. There will be, in the coming weeks and months, a series of ERS webinars run through the European Rhinologic Society, which you can sign up for. And as I've said already, as things change, we won't wait till the next big bang of EPOS, whatever. We will be doing specific area revisions and publishing them separately. So, thank you very much. I'm going to stop the sharing and I am at your disposal.
Thanks so much, Prof. A huge body of work there. Clearly, you've spent an enormous amount of time putting this together. Being one of the opinion-based sort of thought processes, I just believe what my ex-prof always tells me, so I believed all of it. It's fine. It's absolutely fine. But it's enormous amount of work, and to be able to share that in 45 minutes took some doing. We may well eventually ask you back to do some pediatric ones at some point as well, although I'm hoping they get quite a lot of that this afternoon, and we haven't really trod on the toes of the national training program this afternoon either. We have some Q&As. I have some as well, but let's start with the audience. It says, what is your experience of long-term antibiotic-induced allergy, atopy, and the use of probiotics?
Well, it's interesting. For CRS, the studies on probiotics have not shown a positive effect. If the questioner means, should you use it for antibiotics for allergy and atopy, I think the answer would have to be no, although kind of, particularly as it's in respect of the kind of hygiene therapy, we want to be exposed to bugs, not try and get rid of them. I'm not sure if they mean, could it cause allergy or promote allergy? I don't think that would work either. So I think the answer is long-term probiotics are not proven for CRS in the present literature. Some herbal therapies are, but not probiotics.
Probiotics. Yeah. You mentioned about diminishing efficacy of steroids in the long term. Why do you think that is? Why do you think steroids suddenly drop off again? I mean, we all know they work fantastically well in the first few weeks, and we've all had the experience of them coming off again, and they get the problems.
I mean, there's a lot of discussion about it, particularly in the pulmonology literature. Patients have sort of steroid receptors, and I think it's thought that there is some upregulation of the receptors that makes them less responsive. But there are a whole range of possible factors, and as you say, there's no question that the amount you need to get the same response and the duration of that response diminishes with time. And, you know, in a way, that's partly what's led to this interest in the biologics. Who knows, there may be a similar response to the biologics if we keep using them for, you know, month after year after, etc. So it's a question mark. I think it's largely down to the upregulation of the receptors.
Which is a good thing about the biologics, because some of us will still have a job in 10 years. If they...
Sure.
So you mentioned again about the use of oral steroids to help reduce blood loss. Is there good evidence for that?
There is evidence in the literature, yes. I mean, I actually did the section on the adjunctive sort of therapies for optimizing surgery. And I looked at a lot of stuff on anesthesia and preoperative, postoperative, etc. The oral corticosteroid issue is not that it will help during the operation, but that it helps in the immediate postoperative period. But it doesn't help for long. That's the problem. It's the same, you know, discussion as for, you know, as a treatment. So these things will help optimize a situation. The intranasal corticosteroids, for example, optimize the situation. But it doesn't necessarily continue. There's more evidence for the topical than there is for the oral corticosteroids as a preoperative intervention. And there is evidence for oral steroids post-operatively, but not per-operatively.
Moving on to biologics then, and it's something which I actually had a similar question. I mean, I do a similar clinic that I used to do with Glennis and Harsha latterly. And, you know, we do treat some patients with mepolizumab primarily, but it's really for those who have got the severe asthma. So in trusts where biologics are being given, who has been involved in the decision to prescribe, i.e., does there have to be an agreement between management, pharmacy, and perhaps having an allergy specialist or chest physician around?
I think it's a really important thing at the moment. I mean, in a sense, certainly within the NHS, the severe asthma population is sort of the back door in, because, you know, you have a patient, you know, the people say, you know, you've got polyps, how's your asthma? Is it bad? Is it bad? Is it bad? We can send you to the severe asthma clinic and they can give you something.
Absolutely, yeah.
Etc. I mean, that's going to change. At the moment, the pulmonologists are the gatekeepers, and clearly, if you're lucky, you have a good relationship with your pulmonologist, stroke allergist, whoever runs that asthma clinic, and they will be receptive to that approach. I'm sure that's going to change. I mean, clearly, you know, there's going to be more of these drugs coming on the market, and they are going to be licensed for CRS, and so it's going to be a funding decision as well at the CRS level. In the private sector, of course, you can get these drugs whatever at the moment, if you know the right people, and you know you don't have to have asthma at all. And certainly that's the case in other parts of the world. I mean, it's much easier to get these things in, say, the States than it is in the UK. Having said that, I mean, the pulmonologists there still have quite a say in many institutions as to who gets these drugs, because, you know, it is a big financial commitment. It will change. I mean, I always say dexamethasone, when it was launched, cost about £500,000 a dose or something, you know, in the 1950s, if you scale it up on inflation. And, you know, with time, these drugs will come down in price for sure. So that, you know, in 5 years' time, we might find that they are really relatively cheap if they work long term. That's the big issue.
I think there's also the commitment of patients having to come in for the medication. It's not a tablet form yet.
Subcutaneous, you see. I mean, like all the migraine medication went on to, you know, jabbing yourself. You know, I think that there's a possibility. As long as there's good data showing there's very little chance of anaphylaxis, then, you know, you could just give yourself the subcutaneous dose in due course. But they're all going down that route, smaller amounts and not intravenous.
COVID question. I'll ask you one from the audience, and I'll ask one myself. Do you envisage NHS endoscopic sinus surgery being rationed more so than pre-COVID for management of CRS in light of the COVID problems?
I don't see why it should be, frankly. I see no reason for there to be any relationship between the two. I mean, the fact that patients get some loss of smell in many cases, or in the milder forms, I don't think, apart from disentangling that from, you know, chronic rhinosinusitis as a diagnostic phenomenon, I don't think if patients have CRS and they need surgery, I don't think that it can be used in any way as a target, because, you know, all the data is there to show that this is a very significant condition in terms of quality of life, productivity, etc., etc. So they're not on very strong ground if they choose to use that.
Although even in our region, we're being asked to justify every case with a letter of pre-approval for endoscopic sinus surgery, which is, so I guess the question perhaps is a valid one, albeit we've got to fight against these sorts of things coming through. You mentioned tranexamic acid.
Yes.
Are you now using it routinely during endoscopic sinus surgery?
No, I don't, but I'm a great fan, actually, because I started using it a little while back for my HHT patients, and it really does help them a lot. I must admit, I mean, maybe it's a sort of personal thing, we're very fortunate at Grayson Road to have fabulous anaesthesia, and they just produce the most wonderful surgical fields with the pressure and the gases and the TEVA and all the rest of it. So at the end of the day, it was rare for there to be a bad problem with the field. So I never actually needed to give it. But I think it is an option if you're not in an institution where people are happy to provide you with a good field for various reasons, then it's certainly an option, and it's a safe option, actually.
A practical question. Is it your practice to discharge patients early after surgery if they achieve control, with instructions given back to the GP if needed? Or do you do long-term follow-ups given the likelihood of further intervention?
I think it's a difficult one, isn't it? I mean, the onus on us these days is to try and discharge patients. And actually, I think that's a good thing, because with the exception of tumours where they can't always know when they've got a recurrence, you know, we had patients being seen year after year after year. And actually what the whole awful business has shown is that a lot of these patients, GPs and us, didn't keep seeing a lot of these patients. So I think pragmatically, I certainly do discharge patients, but I also have a low threshold for seeing them again. So I think the problem is, and patients are frightened, that once they're discharged, they'll have great difficulty in getting back into the system. I think if you're going to practice that, then you've got to also give patients the opportunity to get access back in. If they can, then they'll be much happier about that. And I mean, one of the things that I was always able to do is use a research nurse, clinical nurse, who, you know, could field inquiries from patients all the time. If they felt there was something wrong, could they come back and be seen, or could they come back and be seen earlier, etc. And I think somebody like that in the system as a sort of gatekeeper can be hugely helpful in triaging things and making patients very comfortable about being discharged back to the GP. So in principle, I think we should be a bit more proactive.
I'm going to ask a question of my own, if I may. We're all moving back, sort of, towards normality. Where do you see us, or what do you see, or I don't know if you've been involved in any groups talking about this, how do you see us getting back to normality with endoscopic sinus surgery, particularly with powered instrumentation, and the risks involved with that?
I think it's very difficult, actually. I don't know. I mean, I'll be honest, I haven't operated during this period at all. And I'm not directly involved with, you know, what PPE is being used, etc. I mean, clearly there's been a lot of inadequacy in the system, and yet there are possibilities for more adequate protection. And if that was available, then I think that it would be reasonable to use it. But it is, you know, a question of having the appropriate protection. That applies, as I say, particularly to, you know, skull-based work and anything that involves, you know, aerolization, etc. So I think if there's a will, then it can be done in the same way as, you know, completely sterile tents were created for doing hip operations in the distant past, etc. You know, so I think we can provide those facilities, or get, you know, it can be developed. It's just that it's been extremely patchy in the present last few months.
I mean, I certainly haven't been involved in discussion necessarily with FAIRS, but we've been talking a lot about it for the rhinoplasty and the facial plastics aspects of what we do. And I think there seems to be a generalized consensus that PPE and everything is going to be important, but probably the most important thing is pre-op screening. Yes. Ideally, what you want is the patient, because I mean, you haven't seen the PPE, but it's pretty tough to wear that for a lengthy period of time. I mean, it's very claustrophobic, it's very hot, and certainly if you're doing 2.5 hour procedures as we do with rhinoplasties, etc., it's almost impossible to do that effectively. And so I think the pre-op screening is going to be the critical thing, and everything else will be a protection. But I think the most pre-op thing is the way to go. I'm just going to see if we've got any. I think there's been a lot of repetition, a lot of questions about the herbal medications. Anything that you know of specifically that's got good evidence, or otherwise?
Well, there's a number of commercial preparations, Sinopret, and things which involve, you know, the roots of bulbs from the Georgian steppes, and, you know, other. There's a whole raft of preparations that are on the market that can have had proper RCTs done. And if you go onto the document, as I say, there are a number of reasonable trials to support their use, because actually we've been involved with the companies on these things, and when they wanted to sort of do this, that and the other, they said, we're going nowhere until you do a proper RCT. And to give them their credit, they have gone away and done proper randomized controlled trials for them. They're mainly intranasal preparations, they you know, have got the evidence to support their use. So, you know, good on them.
Well, I think we'll call it a day there.